Good day, colleagues. Firstly, I would like to express my sincere thanks to Professor Wu Binjiang for the opportunity to present the study. I am presenting the study on behalf of Professor Qiu Caixia and Professor Wu Jinsong from Fujian University of Traditional Chinese Medicine. Let me begin with a very simple question. Would you trust an AI teaching assistant not to run email, not to recommend a restaurant, not to summarize an article? I mean to help you learn clinical medicine. Imagine an AI teaching assistant sitting beside you and your students during their study. It answers questions, challenges their reasoning, gives feedbacks, simulates patients, and adapts explanation according to their levels. Would you trust it? And perhaps more importantly, will your students trust it? This is the question that I want us to explore today, because the future of an AI in clinical education will not be determined simply by how intelligent AI becomes. It will be determined by whether students see it as useful, trustworthy, safe, and educationally appropriate. Here is the first paradox. Students may use AI without actually trusting AI. Students may use an AI system because it is fast. They might use it because it is available 24 hours a day. They might use it because they are embarrassed to ask a basic question in front of their peers. But using something does not necessarily mean acceptance. This is a difference between use, trust, and acceptance. A student can think, I don't completely believe this answer, but will use it to get started. This is usage. Acceptance is much deeper. Acceptance means that I understand what this technology is good for. I understand that its limitation. I know where I should use it and where I should not. And this distinction is critical in clinical education because our goal should not be to produce students who simply use AI. Our goal should be to produce students who can use AI intelligently. Students have never learned from a single source. They learn from lectures, they learn from clinical supervisors, they learn from patients, they learn from peers, they also learn from textbooks, guidelines, videos, and online resources. And now we have another participant entering this ecosystem, AI. The interesting question is therefore not will AI replace a teacher? I think that is the wrong question. The better question is where should AI belong in a learning environment? What should AI do particularly well? Perhaps it can provide unlimited opportunity for practice. Perhaps it can generate cases. Perhaps it can act as a simulated patient. Perhaps it can provide immediate feedback or formative feedback. But there are some also things that we may not want AI to replace. Human judgment, for instance, professional role modeling, empathy, clinical reasoning, and the relationship between educator and learners. So AI needs to find its place within the educational environment or learning environment, not to take over the ecosystem. So what exactly do we mean by an AI teacher assistant? I would define it as quite simply, an AI teaching assistant is a system that supports learning through explanation, questioning, feedback, simulation, and personalized guidance. Notice something important about the definition. I did not say an AI system that gives students answers, because I think that is one of the most interesting opportunity and dangers of generative AI. AI can explain, it can question, it can provide practice, it can give feedback, it can provide personalized learning. and it can potentially create a learning environment in which students can repeatedly practice without fear of embarrassment. That's potentially transformative, but only if we design it around learning rather than around technology. And we need to make an important distinction. An AI teaching system is not an AI clinician. Its purpose is to support learning. That's fundamentally different from making clinical decisions. The risk profile is different. The responsibility is different. And the level of human oversight must be different. Even AI teaching systems give you a student a poor explanation of a concept that is a serious educational problem. But if an AI system provides an appropriate advice about a real patient, and we have entered an entirely different territory. So as educators, we need to establish the boundaries. AI can support clinical learning, but clinical responsibilities remains a human responsibility. This brings me to the framework that I want to propose, thinking about students' acceptance as being influenced by 5 factors. Firstly, usefulness. Does AI actually improve learning? Secondly, trust. Can students believe and appropriately evaluate what it tells them? Thirdly, usability. Is it easy enough to use that students will actually engage with them? The fourth is the fit. Does it fit the curriculum, the assessment system, and clinical learning environments? And finally, perceived risk. What happens when the system is wrong? So conceptually, a system is driven by usefulness, trust, usability, and fit, and constrained by perceived risk. The important point is that intelligence alone is not enough. The world's most AI will not automatically become a good teaching system. Students need to experience educational value. They need to understand its limitations, and they need to use that and they need to see that it is used in legitimate within their learning environment. This start with useful. Imagine a student ask, "What's the diagnosis?" AI can give an answer in a second, but is that necessarily good education? Now imagine that instead of that AI saying, what additional information would you want before forming your differential diagnosis? And then why would that information change your thinking? And then what finding will most strongly change your probability? Now something different is happening. AI is no longer seems simply an answer machine. It becomes a thinking partner. And this is where I believe that educational opportunity becomes more interesting. The value of AI may not be that it knows the answer. The value may be that it can continuously ask the next useful question. In clinical education, that matters immensely because we do not simply want students to know the facts. We want students who can reason. But there's a danger. Convenience can become cognitive offloading. There's a healthy pathway. Think, ask AI, reflect, and understand. But there's another pathway. Ask AI, copy, submit. The two students may have produced exactly the same answer, but only one have necessarily learned. This is why I am cautious when people say AI will make education more personalized. Hence, it will, but personalization is not the same as learning. If AI removes easy struggle from learning, it may also remove some of the thinking that learning requires. So educational challenge is not simply to make AI more helpful. It is to design AI so that It helps students to think rather than think instead of them. Now let's talk about trust. Because in clinical education, being wrong matters. If an AI system give you a wrong restaurant recommendation, you have a disappointing dinner. If an AI teaching assistant give you students an incorrect clinical explanation, something more concerning can happen. The student may remember it. The student may incorporate it into their reasoning. The student may repeat it in an examination, and eventually, potentially, that incorrect reasoning can become a clinical habit. If the student find out this, he need to unlearn in future. And so the question is not, can AI make mistakes? Of course it can. The question is, how do we teach students to recognize and manage those mistakes? This is where the concepts of calibrating trust become important. We don't want students to blindly trust AI, but we also don't want them to reject it completely. We need something in between, calibrated trust. Trust when the system is reliable, verify when the stakes are high, question when something does not make sense, and recognize when the system is operating outside its appropriate role. This is actually a new educational competency. We have traditionally taught students how to evaluate information from textbook, journal articles, and clinical guidelines. Now we also need to teach them how to evaluate information generated by AI. The goal is not just AI, and it is not don't trust AI. The goal is know when to trust AI. So what builds the trust? I would suggest let's identify things. Accuracy. Students need confidence that the system is generally reliable. Transparency. They need to understand that where information comes from and what system can and cannot do. Consistency. If the answer changes dramatically depending on how the question is phrased, trust will suffer. Explainability. Students need to be able to interrogate an answer rather than simply receive it. And finally, human oversight. Students need to know that educators and institutions remain accountable. This is important because trust is not purely a technical property. Trust is something that we design into the educational relationship. And this brings us to perhaps the most overlooked variables, the educator. Students don't experience AI in isolation. They experience AI within curriculum, within an assessment system, within medical school, within culture created by educators. Imagine one lecturer saying, AI is cheating, don't use it. And another lecturer says, use AI to challenge your reasoning, but verify every single clinical claim. Students receive very different messages. So student acceptance will depend partly on what educators permit. Model, expand, and access. We therefore cannot ask only, what do students think about AI? We should ask, what are we as educators teaching students to think about AI? This challenges the role of an educator. Traditionally, we might imagine teacher, knowledge, students, but that model is becoming less sufficient. Students can now access explanations most instantly, so the educators' value increasingly shifts towards being a curator, a coach, a verifier, and facilitator, and a guardian of professional standards. AI may automate some teaching tasks. It may generate questions, it may provide preliminary feedback, it may simulate conversations, but it cannot outsource educational responsibility. The educator remains responsible for decision. What should students learn? What should they practice? What should they question? And what should they never delegate? This, I think, is where our role becomes even more important. So let's stop asking, what can AI do? And ask instead, what do students need? They need feedback. They need opportunity to practice. They need personalization. They need explanations. And perhaps more importantly, they need opportunity for safe failure. Imagine a student who is nervous about taking a clinical history. With a human patient, they may only get a limited number of opportunity to practice. With an AI simulated patient, they could practice 10 times. They can make mistakes, they can start again, they can ask questions, they can become more confident. This is potentially one of the most powerful applications of AI in clinical education. Creating space for students to fail safely before they have to perform professionally. Acceptance is not a switch. It's a journey. Students may begin with curiosity, the experimentation, and then they discover whether AI is actually useful. If the experience are positive, trust develops. Eventually, AI can become integrated into their learning. Finally, acceptance emerges. But that journey can also move backwards. One serious error, a private concern, poor system design, lack of institutional guidance, or an educator who strongly discourages its use, and any of these can determine acceptance. So acceptance is not simply something that we measure at the end. It's something that we shape throughout the learning experience. So what do we do tomorrow? I propose a simple framework: allow, guide, and restrict. Allow AI where education risk is low and the benefits is clear. For example, brainstorming, explanations, revisions, and practice questions. Guide the AI use when students need structure and verification. For example, clinical reasoning, case discussions, and simulated feedback. And restrict AI where consequences are high. For instance, automate clinical decision, high stakes assessments, unverified advice about a real patient. This gives us something more useful than saying AI is good or AI is bad. Instead, we ask, what's the educational purpose? What's the risk? And what level of human oversight is required? And so I want to return to the question we started with. The question is no longer, can AI teach? Because clearly AI can already explain, question, simulate, and provide feedbacks. The more important question is, how should AI participate in learning so that students become better clinicians? This is a very different question. And it puts the responsibility back to where it belongs to, with educators, institutions, students, and professions. So let me leave you with 3 principles. Make it useful. If AI don't improve learning, students will have little reason to accept it. Make it trustworthy, not perfectly trustworthy, because no technology is, but transparent, verifiable, appropriate governed, and finally, make the student think. Because our ultimate goal is not to produce students who can generate excellent answers, it is to produce clinicians who can reason when the answer is uncertain, clinicians who can recognize when something does not make sense, clinicians who can question technology rather than blindly follow it, and clinicians who understand that responsibility cannot be dedicated to a machine. So, perhaps the future of AI in clinical education is not about AI replacing the educator, but it is about something much more interesting: human designing better learning with AI. Thank you, and hope you have a fruitful day further.